Set 20 ISS ISE Technical question and answers. Answers are highlighted in green. Question 1. What is the main purpose of an integrated summary of safety ISS? The option A is to summarize efficacy across all studies. Now, the question is related to safety, so it is not related to efficacy, right? So, A is not the right answer. To validate the statistical analysis plan, says option C. Now, we are talking about ISS safety, right? We are not talking about SAP. So, this is not the right answer. To define adverse event coding standards. Now again we are talking about ISS, that is integrated summary of safety. We are not talking about adverse event coding standards, right? So this is not the right answer. So the correct answer is to pull safety data from multiple studies for regulatory review. Now as you know, the ISS is a combination of multiple studies, right? So option B is the right answer. So ISS pools and summarizes safety data from multiple clinical studies for regulatory submission. Question 2. In which section of the NDA MMA submission are ISS and IC typically included? Module 1, no. Module 3, no. Module 4, no. So the correct answer is Module 2, which is clinical summary, right? ISS and ISE are part of the clinical summary in Module 2 of the CTD format. Question 3. Which datasets are primarily used to create the ISS? The option E is SDTM, DM, EX and QS. Now we are talking about the datasets that are used to create ISS. So these are the SDTM domains. So this is not the right answer. CSR listings only. Now we are talking about the datasets, or not talk about the listings. So this is not the right answer. Raw CRF data only. So the question is referring to the data sets and not to the CRF raw. So this is not the right answer. So the data sets that are used to create the ISS format is nothing but your ADAM data sets, which is the final version, right? So here it is ADAE, adverse events, ADLB, which is related to laboratory, ADVS, which is related to vital signs, and ADRG is the reviewer's guide. So the correct answer is B. ISS relies on ADAM safety datasets like adverse events, lab and vitals. Question 4. Why is pooling of safety data across studies important in ISS? Option A says to reduce the cost of study conduct. No. To ensure consistency of treatment of missing data. Well, you cannot perform any kind of analysis on missing data, right? So this is not the right answer. To align with FDA 21 CFR part 11. It's not about the ISS studies, they need to align with FDA 21 CFR part 11, right? Any clinical trial study that is being conducted, all the studies they have to align with FDA 21 CFR part 11. So this is not the right answer. So the correct answer is to increase statistical power for rare safety events. So the correct answer is C. Pooling increases sample size, which helps detect rare adverse events. Question 5. What is the main difference between ISS and ISE? Option B says ISS is mandatory and ISE is optional. No. ISS is included in Module 4, ISE in Module 5. No. ISS uses raw data, ISE uses summaries. No. So the full form of ISS is nothing but the integrated summary of safety, which focuses on safety. ISE is nothing but the integrated summary of efficacy, which focuses on the efficacy. So the correct answer is A. So ISS is your safety summary, ISE is your efficacy summary across studies. Question 6. When creating an ISS, what is the most critical consideration for pooling safety data from different studies? Option B, ignoring missing data. Well, you cannot ignore missing data. Even missing data, they might need to be presented in some way or the other. Option C says use separate safety cutoffs for each study. No. Performing analysis only for primary endpoint. No. ISS studies are required to perform each and every analysis that is included in the study and as per the statistical analysis plan. So this is not the right answer. So the correct answer is ensuring consistent data formats and coding dictionaries. So the consistent data standards, which is MEDRA, WHO drug and formats are critical for pooling. So whenever you're doing the pooling of multiple studies into one, there has to be a consistent in data formats, coding dictionaries, wherever the labels that are concerned, the variable names that are concerned, the length and the attributes, each and every things needs to be consistent when you are merging. Question 7. Which regulatory guideline provides details on ISS and ISE requirements? Option A, ICH E6, which is related to GCP. No. ICH E3, no, which is related to format of structure, right? ICH is Q2, no. So the correct answer is ICH M4E. ICH M4E defines clinical summaries including ISS and ISE for CTD submissions. Question 8. In ISS, how are treatment emergent adverse events typically defined? Option A, any AE occurring within 30 days of last dose. No. Any AE before first dose of study drug. Well, this is not the definition because adverse event might occur after consuming the first dose, not before. So this is not the right answer. Only serious adverse events? No. We have to consider all kinds of adverse events. So any adverse event occurring after first dose and before last dose, which is related to follow-up. In short, like any adverse event that is happening during the conduct of the clinical trial study from beginning of the first dose to the end of the last dose. So those are your treatment emergent adverse events. So the correct answer is B. Treatment emergent AEs occur post first dose and up to follow-up period as per the protocol. Question 9. What is the primary statistical approach for combining data in an ISE? Option B, chi-square test only. No. Logistic regression. No. The Kaplan-Meier only. No. So the correct answer is meta-analysis or pooled analysis. So the correct answer is option A. ISE uses meta-analysis or pooled analysis across multiple studies for efficacy. Now remember one thing, ISE and ISS, they are the combination of multiple studies. So that you need to do the pooled analysis. That is why we use the meta-analysis, which is nothing but your pooled analysis. Question 10. During ISS preparation, a sponsor notices inconsistent adverse event coding between studies. What should be done? Use specific study coding without changes. No. You have to make some changes. Drop studies with old coding. No, you cannot drop those studies which are related to old coding. You have to again recode them to the nearest code level. Report only SOC level without changes. No, you have to report all kind of system organ class, preferred term and the verbal term, whichever is a high level, low level term, each and everything you need to mention. So you need to map all adverse events to the latest MEDRA version that is being used, and that should be present in the statistical analysis plan of ISS study. So the correct answer is B. Harmonizing AE coding to the latest MEDRA version ensures consistency in ISS. Question 11. In an ISE, two pivotal studies show positive results for the primary endpoint. What is the most appropriate approach? Option A, exclude the negative study from analysis. No. Perform a pooled analysis without explanation. No. Even if you're performing any pooled analysis, you have to explain it, right? Report only the positive study. No, it's not about the positive or negative study. Whatever the study that is presented or is decided to continue, you need to discuss that. So in that situation, you can use the meta-analysis and discuss the heterogeneity. So the correct answer is C. Meta-analysis with heterogeneity discussion is required to justify differences in efficacy outcomes. Question 12. While preparing ISS, you find that one study used WHO Drug Dictionary version 21 and another used version 23. What should you do? Leave them as is and explain differences. No, you cannot leave like that. Exclude the older version. You cannot even exclude such older version data. Create separate summaries per study. No, you need to combine and convert all the studies to the latest WHO drug version, right? So the correct answer is B. For consistency, remap to the latest WHO drug version for pooled safety analysis. Question 13. For ISS, which statistical method is recommended for comparing incidence of adverse events between treatment groups across studies? Option A, Fisher's exact test for each study separately. No. Kaplan-Meier curve, that is related to your survival analysis. So this is not the right answer. Option D says logistic regression without covariates. Now this is not related to adverse events. So the comparing the incidence of adverse events across group, the correct statistical method or the test is mental Hackensen stratified risk difference or odds ratio. So this method is commonly used to compare AE incidence across pooled studies. Question 14. Which situation would require a subgroup analysis in ISE? Option A, when all studies have similar efficacy results. No. When pooling causes zero adverse events in the group. No. When only one study had efficacy data. No. Even if you have only one study which is having the efficacy data, how can you do the subgroup? Subgroup is where you need to have the sufficient data across all multiple studies. So the correct answer is when regulators request ethnicity specific results. So if the regulator is asking you to perform any ad hoc request or any other additional information that they want, in those scenarios they can ask you to perform the subgroup analysis. So regulatory agencies often request subgroup analysis, for example age, gender, ethnicity for the efficacy. So the correct answer is B. Question 15. During ISS preparation, one long-term safety study has 2-year duration while others are 6-month studies. What is the best polling strategy? Option A, combine all without adjustment. No. Pool all but analyze long-term data separately. So this is the right answer. Drop the long-term study. No, you cannot even drop the long-term study. Average exposure durations across studies. No, this is not the right answer. So whenever you have a one study which is long with two years and another is related to 6 months, so you need to pool everything, but you need to analyze long-term data separately. So long-term study should be summarized separately and compared to the pooled short-term data. Question 16. In an ISS, which exposure adjusted metric is most useful for comparing adverse event rates across studies with different treatment durations? So option A is incidence proportion, which is percentages. No. Odds ratio. No. Hazard ratio. No. So comparing adverse events rate, the correct answer is incidence rate per 100 patient years. So this is the right answer. Incidence rate per 100 patient years adjust for differences in treatment exposure. Question 17. Which of the following best describes the purpose of a common safety table shell in ISS development? Option B, to apply separate templates for each study. No, you cannot have a separate templates for separate study. To include only raw listings without summaries. No. You need to perform the listings, then the tables and the figures whenever you are doing the ISS study. To create custom tables for each regulatory. No, even if you have different regulatory, that does not mean you create separate tables. So the correct answer is to ensure consistency of table formats across studies. That is the reason we keep the common safety table shell, which is the common for all ISS studies. Common shell ensures consistency in pooled safety tables for regulatory submissions. Question 18. When preparing an ISE, what is the best method to address differences in primary endpoints across studies? Option A, exclude studies with different endpoints. No. Even if they are different, you cannot exclude them. Report only one endpoint for all studies. No, whatever the endpoints that are there, especially in all the 12 or multiple studies, you need to come up with the harmonized primary objective, the secondary objective and the exploratory objective, and find out that which are the endpoints. And if the sponsor says that I need to mention each and every endpoint analysis needs to be present in the ISS, then you don't have any choice to exclude them. Ignore differences and pool data. No, you cannot ignore the differences. So the correct answer is standardize endpoints or use sensitivity analysis, right, as per the sponsor request. So standardizing endpoints or performing sensitivity analysis helps handle endpoint variations. Question 19. Which FDA guidance specifically provides details on integrated summary requirements for NDA submissions? Option A, FDA E6 guidance. No. Option B, FDA guidance on integrated summary of effectiveness and safety. So this is the right answer. ICH Q8, no. CDISC is related to your ADAM implementation guide. So this is not the right answer. We are talking about the ISS requirements for the NDA submissions. So the FDA has a specific guidance on integrated summary of effectiveness and safety for NDAs. Question 20. If a regulator requests justification for excluding a particular study from ISE, what should the sponsor provide? Now, option A says a summary stating the study was negative. No. A statement that inclusion was optional. No. A separate ISS addendum. No. So the correct answer is a scientific rationale documented in the clinical summary. So you need to provide a specific rational reason, the scientific approach. So the scientific justification must be documented in the clinical summary as per the regulatory expectations. Please like, share and subscribe. Leave a feedback comment mentioning any topic that you want me to make a video. Looking forward for a positive response. Thanks for watching. Please like, share and subscribe. Leave a feedback comment. Many thanks for your support and having great connection.